Hi guys, good evening. Can you all see me? Can you all hear me? I hope so. So we are here with another series of compounding. So the last week we did question number 1 to 7. Hi Dhruv, good evening, good evening. Now, so आज we'll discuss from question number कौन सा है? Question number 8 से ना 7 खत्म हो गया या question number 8 ठीक है. So आज का opening question, I think you've been following the post, so you would have seen this is our question. Right, so let's get started and then we'll look into the prospect as we move forward. Okay. Right. So in the question number 1, what do you have? In the question number 1, we have a 42-year-old female presented with recurrent episodes of right flank pain, hematuria, and a history of urinary tract infection. Urine analysis shows an alkaline urine with a pH of 8. Which of the following is the most likely underlying cause for this patient's condition? And there is an image given for urine crystalline, that is crystallography, and this is what we call it as, or this presents to you as a coffin lid sign, right? So this is like coffin lid. So by the coffin lid, I know that I'm looking at the phosphate stone. I'm looking at a phosphate stone. Now the phosphate stone, the phosphate stone, when you look at this is also called as the struvite stone. Because of its brittle nature, this is also called as the triple stone. Now why is it called as the triple stone? Because it has got the ammonium, magnesium and the phosphate. There is an ammonium salt, there is a magnesium salt as well as the phosphate, and because they all present together, this is what we call it as the triple stone. In fact, this is considered to be as the most radio opaque stone. This happens to be the most radio opaque stone overall. This happens to be the most radio opaque stone. This is the most radio opaque stone overall, right? So when you look at the phosphate stones, so this is going to be also called as struvite stone. It is also called as triple stone. This is the most radio opaque stone, right? Now what is the causative agent, right? So the causative agent, when it comes down to the phosphate stones, they are infectious in nature, right? So can anybody tell me, if you're listening live across, can anybody give me an idea sorry, right, if anybody can give me that what is the prime cause, or what is the most common organism causing the phosphate stones? Quick feedback. The most common organism it is caused by the protease infection. Now protease is a urease producing bacteria. It converts the urea into ammonia, right? Urea is water soluble, ammonia is not, so it gets retained, so hence the pH of the urine will also increase. So that is why you have the alkaline urine that is present. So here I can say it is not a uric acid stone, it is not a calcium oxalate monohydrate, it is your, as we said, it is your triple phosphate stone. It is not a calcium oxalate dihydrate stone, right? So when you look at the couple of images, so this has been your previous exam question. All those who've been asking us, sir, what is this compounding series? We have started with the previous year questions, and this is from your INI-CET. So first 7 was also INI-CET. This is also your INI-CET questions, right? Now, so you'll get images like this, right? So if you have an hexagonal crystal, if there is a hexagonal crystal, which is also commonly called as the benzene shaped crystal, there's a hexagonal crystal, also benzene shaped crystal, it is what we call it as the cystine stones. Now we all know cystine stones are considered to be as one of the most hardest stone. This is going to be one of the most hardest stone. This will be black in color. This will be black in color, and this is going to be hard stones. Now this is what we have, the coffin lid. We just read everything that is required for the coffin lid. Now this is your envelope shaped crystals. Now envelope shaped crystals which are here, these are your calcium oxalate stones, that is a dihydrate. In fact, this calcium oxalate happens to be the most common type of the renal stone. This is the most common type of the renal stone. Then you see a nice archy one. This is like this, right? So this depicts something like this. No, this is like a dumbbell stone. So this is a dumbbell crystal, and the dumbbell crystal seen in calcium oxalate. They're seen in calcium oxalate monohydrate. There's a calcium oxalate monohydrate, right? Now this is your multi-faced. This both are the examples of multi-faced crystals, and the multi-faced crystals are seen in uric acid stones. They're seen in the uric acid stones. Now, what is interesting about the uric acid stones? Remember, uric acid stones are considered to be the most common radiolucent stone. They are the most common radiolucent stone. So if they ask you what is the most common radio opaque stone, the answer is calcium oxalate. What is the most common stone overall? That is going to be calcium oxalate. If they ask you what is the most common stone in an infected urine, the answer is going to be a phosphate stones. Which is the most common radiolucent stone? The answer is going to be your uric acid stones. So do not goof up on this. This is quite important for us to know, right? Now, when they ask you about the renal stones, what is the investigation of choice? See, the investigation of choice for your nephrolithiasis is going to be your NCCT of the kidney. It is going to be NCCT of the kidney, or you can say CT urography. It is going to be your CT urography. It is going to be your CT urography. Right? X-rays are good enough, but CT urography gives you the most competent way. Now, the management for your nephrolithiasis in general, if you talk about it, you have stones less than 5 millimeters. Then you have from 6 to 20 millimeters. Then you have more than 20 millimeter stone, right? Now these are the usual objectives. So stones less than 5 millimeters will go ahead with conservative management. We'll go ahead with conservative management, right? Next comes your stones between 6 to 20 millimeters. So we'll say if it is less than 15 millimeters in size, or if it is more than 15 millimeters in size. If it is less than 15 millimeters, it is usually ESWL, that is your extracorporeal shock wave lithotripsy. It's an extracorporeal shock wave lithotripsy. Now the question that they ask you in ESWL is stones that cannot be broken down by ESWL. Stones that cannot be broken. That cannot be broken by ESWL. Now for this, you can remember as mnemonic as ABC. Number one is your hydroxyapatite stone. Hydroxyapatite stone. Bruchite stone. C stands for cystine stones, which is the strongest that we have just learned. Along with that, one more is calcium oxalate. Calcium oxalate monohydrate. It's a calcium oxalate monohydrate. Now, if it is more than 15, that's when you talk about it is more than 15 millimeters. If it is present in the distal ureter, if it is present in the distal ureter, then you can do a URSL, or also called as retrograde renal surgery, right? So it's a ureteroscopic lithotripsy, or the stone extraction can be done. If it is more than 20 millimeters, then you can go ahead with PCNL, that is percutaneous nephrostomy, right? So PCNL is done if the size is more than 20 millimeters, right? Now, what are the contraindications for ESWL? Just a quick recap on that as well. What are the contraindications? I'll just mention it here. What are the contraindications for ESWL? The contraindication for ESWL, number one, obesity, where the shock wave cannot reach. Second, if there is presence of distal ureteric strictures. If there is presence of distal ureteric strictures. If patient has bleeding disorder. If the patient has any bleeding disorders, and in pregnancy, shock waves are contraindicated. Okay. Another one, the last one is, yes, presence of multiple stones. Presence of multiple stones, right? Dhruv, you are absolutely spot on, beta. Absolutely spot on. Okay. Chalo. So this is all the important points here. So the question number 8 that we have on the day 8. So we are running on day 8. So the answer to the question for the day 8 is going to be your triple phosphate stone, right? Correct. See, low-lying calcial stones and all, they are also but they're relative contraindication, right? For that, you will go ahead, your retrograde renal surgery, that is a URSL, can be done for them. Okay? Chalo, great. Now let's go to question for day 9, right? Now, when you look at the question for day 9, it says, sorry. Okay. It says, which of the following statements are true regarding Wilms tumor, right? So looking at the Wilms tumor and looking for true, but then you have one more catch. What is the catch? What is the catch? The catch is except. So all of the following are true regarding Wilms tumor except, that means you're looking for a false statement, right? Now, what are these false statements that you have? Let's look at the statement number 1. The statement number 1 says the most commonly present as abdominal mass, absolutely correct. Wilms tumor presents as abdominal mass only. The usual age of presentation is under 5 years. This is also absolutely correct. With radiotherapy and chemotherapy, 95% of the patients live long. Answer is absolutely wrong here. Without surgery, there is no survival. So surgery with chemo radiotherapy has the overall good survival. The histopathology on a favorable side, the 5-year survival is more than 90%. So this is a wrong option. Metastasis to lung is rare. Yes, it is seen only in 8% of the patients and occur at later stage. This is also correct. But then again, metastasis does not mean that you cannot operate. Even there is a metastasis, they respond well to chemotherapy. So hence the prognosis is overall better. So in Wilms tumor, the first 2 statements and the last statement is relatively correct. The one that is considered to be a wrong statement is going to be C for Calcutta. So answer to this question is going to be this, right? So in Wilms, you will see that it has to be done with surgery followed by chemo radiotherapy. Now, what are the important points that you should remember for the Wilms tumor? So, important points regarding the Wilms tumor. Now, in terms of Wilms tumor, remember Wilms tumor is considered to be as the most common pediatric renal malignancy. It is the most common pediatric renal malignancy. It is the most common pediatric renal malignancy. But if I change the question to the most common abdominal malignancy in children, the most common abdominal malignancy in children, so the answer is going to be neuroblastoma. Here the answer is going to be neuroblastoma, right? But if it's a pediatric renal malignancy, the answer is Wilms tumor. Now, one differentiating point that I can tell you right here, Wilms tumor, it will present to you as abdominal mass. This will present to you as abdominal mass, but this usually does not cross. It does not cross midline. It does not cross midline. Whereas neuroblastoma will also present to you as abdominal mass. This will also present to you as abdominal mass, but this is going to cross the midline. This abdominal mass is going to cross the midline. So usually when you have a midline crossing, that is usually neuroblastoma. See, both of them actually present to you at the age under 5 years, so I can't really distinguish on the basis of age. But these are the 2 points that I can say based upon their presentation that I can differentiate, that Wilms will not cross the midline, whereas neuroblastoma will cross. Neuroblastoma, another thing that you will see is present of periorbital ecchymosis, that is called as raccoon eyes. So there will be presence of raccoon eyes. Raccoon eyes presentation is seen in your neuroblastoma, right? So what are the other important points that you have? The other important points that you will notice that when you talk about the Wilms tumor, the clinical presentation of the Wilms tumor, number 1, it is going to present to you with abdominal mass. It will present to you as abdominal mass. Along with abdominal mass, it is going to present to you with hematuria. So usual presentation is going to be of abdominal mass with hematuria. Now, it is usually, when you talk about the genetic component, the Wilms tumor is usually sporadic. It is usually sporadic when compared to the familial component. So this is usually sporadic, not familial, right? When you talk about familial, you should know that Wilms tumor is associated with other disorders or the syndromes, right? So familial syndromes, which is associated with Wilms, remember familial will usually have presentation of bilateral Wilms tumor. They will usually have presentation of bilateral Wilms tumor. So what are the conditions which are going to be associated with this? Number one, you have the overgrowth syndrome, that is your Beckwith-Wiedemann syndrome. This is associated with Beckwith-Wiedemann syndrome. I hope everybody knows Beckwith-Wiedemann syndrome. In the Beckwith-Wiedemann syndrome, it is associated with chromosome number 11p. What is the component that they have? In Wilms tumor, I hope everybody knows the gene also. No? This is your Wilms tumor 1 gene, WT1 gene mutation, right? So in Beckwith-Wiedemann syndrome, it is 11p. When you talk about the features that you have, hemihypertrophy, macroglossia is there, visceromegaly will be present. Then the patient is going to have in terms of presentation, you will see that limb abnormalities are there. So you have omphalocele is another presentation. So hemihypertrophy, macroglossia, visceromegaly. In visceromegaly, it is associated with hepatoblastoma also, it is associated with Wilms tumor also. And then you have omphalocele also. So these are the conditions which are associated with Beckwith-Wiedemann syndrome. Now, apart from that, these also associated with Danish-Drash syndrome. Associated with Danish-Drash syndrome. It is also associated with Wager syndrome. Also associated with Wager syndrome. So what is this Wager syndrome? In Wager, W stands for Wilms tumor. A stands for aniridia. G stands for your genitourinary abnormality. And R stands for mental retardation. R stands for mental retardation. Now the investigation of choice. The investigation of choice for the Wilms tumor is going to be CCT of the abdomen. It is going to be a CCT of the abdomen. Now when the mainstay of the management, when you talk about it, it is going to be surgery followed by chemo and radiotherapy. Right, there's both chemo and radiosensitive, so this is what you're going to follow for Wilms tumor, right? So here the answer is going to be without surgery there is no prognostic factorization, so here you need to go and address with the surgery in Wilms tumor. Now let's go to day 10. So 10 is the best day. Okay, so day 10, what do you have? Now you have the color coding system question, so this is again important. What is the color code in trauma triage for the patients with life-threatening conditions? So I hope everybody knows the trauma triage, no? So first important question that was asked on triage, right? So triage is done on the basis of. So what is the triage criteria? Now triage is done when you look at the three important criteria. Number, triage is nothing but a color coding system based upon the patient's condition. That's what you're looking at. So triage is a color coding condition. Triage is basically your color coding system. Now the question is, on what basis are you giving these colors out, right? The first important one, it is on the basis of the priority of the treatment. So number one, it is on the basis of treatment priority. Number two, it is on the basis of probability of survival. And number three, it is based on the resources required. Resources required versus resources available. So there are three primary reasons or three primary contexts on which we are going to look for it. It's on the treatment priority, probability of survival, and the resources required versus resources available. Dhruv, it is wrong. It is not on the basis of severity. If I give you an example, let's say I have a patient with aortic transaction, another patient with tension pneumothorax. Out of these two conditions, aortic transaction is much more severe condition and tension pneumothorax is lesser severe condition. But if you are the only person available and these two patients come together, no, who would you attend first? I would attend pneumothorax first because I know the probability of survival is high, but again there's a high risk chance for his death. That is also life-threatening. Two life-threatening conditions which arise at the same time. Whoever has a better probability of survival, you will go and address that patient and then come back to this patient. It does not mean a patient with pneumothorax is there, another patient with laceration will say, no, I will only suture laceration first because the probability of survival is good. No, that is stupid, right? So don't misinterpret things. When two people with equal life-threatening injuries have come, out of these two, whoever has a better probability of survival, I'm going to address that patient first and then move on to the next patient. Okay? So don't make that mistake. So this is on that basis. Now, what are the color codes that we have? So when you look at the color coding component, the first color code that is going to be, so there is, we will number them. There's a number system. Along with number, we have the name, we have the color code, and then you have the description. Okay, so this is standard ATLS protocol that will follow. So we have number P1. P1 basically means this require an emergency. This is an emergency, or I can say it requires an immediate attention. This requires an immediate attention. For all patients who require immediate attention, the color coding system here is going to be red, right? So here we say any patient who has life-threatening injuries. Any patient of life-threatening injury, in simple words, the probability of death is within 1 hour. The probability of death in these patients is within 1 hour if you do not intervene. If you do not intervene. Next comes is your P2. P2 is basically urgent attention. Urgent attention is your yellow color code. It is a yellow color code. So all fractures basically. They'll not die. They'll not die. There's a lot of pain. Yes, agreed. But then you will look for the priority basis. It's going to yellow. Then you have P3. P3 is what we call it as delayed, or also called as the orphan child of casualty. I'm going to put it green. So all your walking, talking patients. All your walking, talking patients. All your walking, talking patients, you're going to put green color, right? Then you have your P4. P4 is what we call it as expectant. And this is your blue. So here, these are moribund patients. These are your moribund patients. Now these patients, the probability of survival is very low. Okay, so it's going to be at a lower priority. So hence, you're not going to waste much of time. Here, you will give a supportive treatment, and then for here, definite treatment is not possible. So either they're moribund or these patients require referral. When I say referral, that means let's say a patient has come with head injury, you do not have CT scan or neurosurgeon in your hospital. Those patients you cannot manage at your place, so you have to send them, right? You refer them to the next place as early as possible, and this is what we got as P4. And the last one is, we don't have a number for it. It's a brought dead patient. The color code here is going to be black, right? So brought dead patients, color code is going to be black. So this is on the basis of your triage color coding system. Now the question here is your immediate life-threatening injuries. For life-threatening injuries, I'm going to put red and send the patient. So the answer here is going to be B for Bombay. As simple as that. Okay? So this is what day 10. Go to day 11. So what do you have on day 11? Day 11, we have a patient. Now there's a patient with papillary cancer, thyroid, underwent thyroidectomy. She developed hoarseness of voice after surgery. We all know hoarseness of voice is because of damage of unilateral recurrent laryngeal nerve. Bilateral recurrent laryngeal nerve will cause medialization of vocal cord, resulting in not able to speak, aphonia, and severe respiratory distress. And then you have superior laryngeal nerve, external branch of superior laryngeal nerve. When it gets damaged, there is loss of pitch, there is no voice modulation. Which of the following steps in the surgery could not, here, this will miss, could not have resulted in this complication? Okay. Now, You need to understand the basic anatomical orientation of the thyroid gland. To answer this question, we'll go a quick recap on this. Let's say this is the representation of the neck. This is the representation of the neck. And let's say this happens to be our thyroid gland that is present. So this is the representation of the thyroid gland, right? Now we have, I hope everybody knows the basic blood supply. So this happens to be the arch of aorta. This happens to be the arch of aorta. This is the brachiocephalic, left common carotid, left subclavian artery, and then it goes across here. Now this brachiocephalic continues as the right subclavian artery, and then it goes as the right common carotid. So this is your right common carotid, which is going to bifurcate into internal and external carotid artery. Same thing on the left side will also be there. This is your left common carotid. This splits into internal and external carotid artery. This splits into internal and external carotid artery. This happens to be your left subclavian artery, right? This happens to be your left subclavian artery. Now, there is a nerve that is going to run. We all know on the left and right side, this is going to be the vagus nerve. So this is going to be your right vagus, and this happens to be your left vagus, right? Now, obviously from the vagus, the branches that are going to come out, number one is going to be superior laryngeal nerve, which will split into internal and the external and the internal branch. So you see the internal branch, the external branch of the superior laryngeal nerve. So the one that is going up is the internal branch, one that is coming down is the external laryngeal nerve. So superior, it is the superior branch of the, external branch of the superior laryngeal nerve that is going to go behind the thyroid gland. Now from here you see, this is your recurrent laryngeal nerve, which is going to go across here. And this is your recurrent laryngeal nerve, which is going to go across here. So you see the recurrent laryngeal nerve, which is on the, so this happens to be your right side, this is your left side. So this is your right vagus. This happens to be your right vagus, and this happens to be your left vagus. So this becomes your left recurrent laryngeal nerve, which is going to encircle the arch of aorta, and this becomes your right recurrent laryngeal nerve, which is going to encircle the right subclavian artery. It is going to encircle the right subclavian artery, right? Now when you look at the thyroid, basically when you see the blood supply, this happens to be the internal carotid artery, this happens to be the external carotid artery. We all know it is the first branch of the external carotid artery which is going to supply to the thyroid gland, and this is basically your superior thyroid artery. Whereas the inferior thyroid artery, when you talk about it, the inferior thyroid artery arises from the thyrocervical trunk. So this is the thyrocervical trunk which is present here from the subclavian artery. From here you will see that it is going to enter. This is going to go and supply, or I can say, I'll just change the orientation of the rectal laryngeal nerve a bit. So this is your inferior thyroid artery, which is going to go and supply to that of the thyroid gland. So on the either side, this is your thyrocervical trunk which is present here. This is your inferior thyroid artery which is going to go and supply here. So this is your inferior thyroid artery, right? So you have the inferior thyroid artery, right? Now, this is our recurrent laryngeal nerve which is going from here. Now you see there's a small triangular area that is formed between the inferior thyroid artery, the common carotid artery, and the recurrent laryngeal nerve. Now this area is what we call it as the Bayer's triangle, right? This area is what we call it as Bayer's triangle, and this is what we have mentioned here. The Bayer's triangle is actually formed. It is actually formed by the recurrent laryngeal nerve, the common carotid, and the internal, the inferior thyroid artery. Okay? Now, once you've understood this basic anatomy, now the question is, when do you think it is going to get damaged, right? Now, just for the sake of understanding, anyhow, we are on the same verge of explaining. I'll take a little bit of 2-3 extra seconds to get the concepts even more better. Now, when you give it a lateral view, now if you take this as a representation of the lateral view, in the lateral view, let's say this happens to be your hyoid bone, which is present here. This happens to be your thyroid cartilage. This happens to be your cricoid cartilage. And this is going to be your trachea. This is going to be your trachea, right? And these are your hyothyroid membrane which is present. This is your thyrocricoid membrane that is present. Now the thyroid gland that is present here, the thyroid gland is going to be located across here. So this is the location of the thyroid gland. This is the location of the thyroid gland that is present. Now you will see the thyroid gland will also have a capsule. So let's say this is the capsule. So let's say this is the capsule which is now covering the thyroid gland. Now this capsule is nothing but the investing layer of the deep cervical fascia, and you see this happens to be your pretracheal fascia which is present here. So the green one that I'm describing is your pretracheal fascia. Now this investing layer of the deep cervical fascia is going to condense, and it is going to form a tuft of band, and that band is going to attach to that of the pretracheal fascia, and this band that is getting attached here, the band that is getting attached here, the band that is getting attached here is what we call it as the Berry's ligament. This is what we call it as the Berry's ligament. Now why this is important is when the recurrent laryngeal nerve is going to enter, the recurrent laryngeal nerve comes and it goes above the Berry's ligament like this, right? So we all know recurrent laryngeal nerve is going to go and supply to the vocal cord. So this is the passage. In fact, one of the most common sites, in fact the most common site for the injury of the recurrent laryngeal nerve is when you are dissecting, the Berry's ligament. Just next to the Berry's ligament, slightly above or slightly up on a context here, you will see there is a tubercle which is present here. There's a slight protrusion on the posterior surface, and this is what we call it as the tubercle of Zucker-Candle. Now this Zucker-Candle's tubercle is when your thyroglossal duct comes and descends the thyroid gland down. When it regresses, it leaves a small component, and that component is your Zucker-Candle. So when you're dissecting or when you're trying to go near the organ, Zucker-Candle's tubercle, you can still cause damage to your recurrent laryngeal nerve. Okay? So this happens to be your recurrent laryngeal nerve which is just flowing across here. This happens to be your Zucker-Candle's tubercle. Okay. So Berry's ligament, so I said the most common site for recurrent laryngeal nerve injury during surgery is Berry's ligament dissection. When you're going for a Berry's ligament dissection. When you're going for Berry's ligament dissection, right? Now, if you look at the entire representation that we have, what are the sites where the recurrent laryngeal nerve can get injured? Number one, when you're trying to do the dissection at the Zucker-Candles, it will injure. When you're trying to do dissection at the Berry's ligament, it will injure. When you're trying to do the dissection here, what is this point here? This is nothing but your Bayer's triangle. If you're trying to do the dissection at the Bayer's triangle, it is again going to cause injury to the recurrent laryngeal nerve. Okay? It is also going to cause injury to the recurrent laryngeal nerve. Okay? Now coming back to our question. Dissection close to the Zucker-Candle's tubercle, can it cause the injury to the recurrent laryngeal nerve? The answer is yes. Bayer's triangle, yes. Ligation of the superior thyroid artery, it is slightly far away. So now you have a doubt between whether it is a superior thyroid artery or whether it is a strap muscles, right? So when you, in fact, if this option, if it was given for inferior thyroid artery, it would have been even better. If the option here was replaced by inferior thyroid artery, then it would have been a much better option, but then we'll still consider it. Now what do you have? Division of the strap muscles. Now where do you have the strap muscles? So when you go from outside to inside, no. So the outermost layer that you have, is going to be skin. Under the skin, you have the subcutaneous fat. Under the subcutaneous fat, there's a muscle which is inseparable from the fat. This is what we call it as the platysma. Under the platysma, you have the set of muscles on the either side, and these muscles are what we call it as strap muscles. And below the strap muscles, you have your thyroid gland. This is the representation of your thyroid gland that is present. Behind the thyroid gland, you have the trachea. Behind the trachea, you have the esophagus. Between the trachea and the esophagus, you have the recurrent laryngeal nerve. Behind the esophagus, you have the vertebra. And in front of the vertebra, you have the prevertebral fascia. On the lateral to the prevertebral fascia, you have the carotid sheath. In the carotid sheath, you have the common carotid artery, you have the internal jugular vein, and then you have the vagus nerve, right? These are the components which are present. Now, if you have a common sense, strap muscles are here, recurrent laryngeal nerve is here. How can dissection at this plane cause injury to this structure? It is impossible. So in that way, I can say the answer to this question, the answer to this question is going to be division of the strap muscles cannot. The division of the strap muscles cannot result in damage of the recurrent laryngeal nerve. Is that clear? Now, just for the sake of understanding, I'll just label it. Okay. So the outermost structure that you have, this is going to be skin. Then you have the subcutaneous fat. Then you have this muscle which is inseparable. This is your platysma. Under the platysma, you have the strap muscle. So this is the orientation of the strap muscles that you have. This is the orientation of the strap muscles that you have. So this is your strap muscles. So this is the orientation of the strap muscles that you have. So what do you have? These are your strap muscles. Sometimes I get a little bit obsessed with how it drawing is, no? I don't know, I just cannot make crappy drawings. Okay, these are strap muscles. This is your thyroid gland. This happens to be your trachea. This is your esophagus. This is your recurrent laryngeal nerve. This happens to be your carotid sheath. This happens to be your carotid sheath. This is your common carotid. This is your vagus nerve. This happens to be your internal jugular vein. Okay. Now with this, I can say I've done a fair justice to our question in terms of explanation. Division of the strap muscles cannot result in damage to your recurrent laryngeal nerve. Sorted? Clear. Now, let's go to day 12. So what do you have on day 12? Day 12, which of the following condition is not a risk for cholangiocarcinoma, right? Now, cholangiocarcinoma risk factors are very important. Number one, hepatitis B is not a risk factor. In fact, it is the hepatitis C which is considered to be as a risk factor for cholangiocarcinoma. So answer itself is clear. Caroli's disease, yes, it can also associate with your the type. See, Caroli's disease is nothing but intrahepatic multicystic condition, right? Cystic dilatation of the pituitary in the same context. Primary sclerosing cholangitis, yes. Opisthorchus viverni is another one which can result in cholangiocarcinoma. See, when you talk about the malignancies, so not every other malignancy you need to remember the risk factor. The risk factor for breast cancers are important. The risk factors for the colorectal cancers are important. The risk factor for the pancreatic cancers are important. And the risk factor for your cholangiocarcinomas are important. These malignancies, risk factors, you should and must know it, because there is no if and but in that. Okay? So when you look at what are the, just quick recap on all the other risk factors for cholangiocarcinoma. I'll just quickly name it down. Risk factors associated with cholangiocarcinoma. Risk factors associated with cholangiocarcinoma. So when you talk about the risk factors associated with cholangiocarcinoma, I can differentiate them into three categories, right? So what are the three categories that you can differentiate that into? Just give me 1 second, guys. Right. So three categories in which you can differentiate the cholangiocarcinomas. Number one, which is going to be chronic inflammations. One that are associated with the chronic inflammation. One that is associated with the chronic inflammation. Then you have parasites, congenital disorders, chemical agents, and miscellaneous. Right? Now, when you talk about conditions which are chronic inflammation associated with cholangiocarcinoma, number one is your primary sclerosing cholangitis. Then you have hepatitis C virus and oriental cholangiohepatitis. Oriental cholangiohepatitis. Oriental cholangiohepatitis. In parasites, two important parasites. Number one is your Opus thorcus viverni. Opus thorcus viverni. Another one is your Clonorchis sinensis. Another one is your Clonorchis sinensis. For congenital, it is going to be your choledochal cyst and also your Caroli's disease. Congenital choledochal cyst and the Caroli's disease. In chemical, remember thorium dioxide. It is now not used any longer. It was a contrast agent that was given. Now, thorium dioxide is also known to cause thyroid cancers. It is also known to cause renal cancers. It is also known to cause cholangiocarcinomas. Okay? So, thorium dioxide, vinyl chloride, thorium dioxide, vinyl chloride, and asbestos. And the asbestos. When it comes down to miscellaneous, remember any bile duct and bowel anastomosis, that is any biliary enteric anastomosis. Any biliary enteric anastomosis, right? Now, if I say what is the most common site for the cholangiocarcinoma, the most common site for cholangiocarcinoma is going to be hilum, and this hilar cholangiocarcinoma is also called as the Klatskin tumor, also referred to as the Klatskin tumor. It is also associated with the Klatskin tumor, right? So all these are in the context of the risk factors for your cholangiocarcinoma. So answer to this question is going to be our A for Ahmedabad, that is your hepatitis B, right? So here the option should have been hepatitis C. Going to day 13. So what do you have on day 13? Now day 13 says that a woman presented with ulcerative lesion over the breast associated with erythema of the surrounding skin and the retraction of nipple on examination. Biopsy revealed invasive ductal carcinoma. According to 8th edition of AJCC classification, the patient can be classified under which stage? Right, so you have ulcerated lesion is there associated with erythema of the surrounding skin and the nipple retraction of the. So for me, the most important statement here is going to be an ulcerated lesion. Now I need to know that what breast staging are you looking at. Again, a lot of students have asked about this, so let's do a quick recap on this. Okay. Now let's imagine that this is a representation of the breast that we're talking about. This is the nipple. This happens to be your pectoralis fascia. Behind the pectoralis fascia, you have the two important muscles which are supporting it. One, it is your pectoralis major muscle. Another one is going to be your serratus anterior group of muscle. Another one is your serratus anterior group of muscle. This is your serratus anterior group of muscle. Now, behind the pectoralis major muscle, behind the pectoralis major muscle, you have another muscle which is called as the pectoralis minor muscle. You have the pectoralis minor muscle. Okay. Now just for the sake of understanding, if I just quickly give across this is what we have the skin. So this is the skin. This is your pectoralis. This is your pectoralis fascia. Right, this is your pectoralis major muscle. This happens to be your pectoralis minor muscle. You have pectoralis minor muscle, and then you have this is your serratus anterior group of muscle. This is your serratus anterior group of muscle. Right, we'll just change a little bit of orientation. And this is not supposed to happen. So they're adamant, they'll stick there. Okay, we'll stay. Now, let's look at the staging per se. Now we say any size less than 2 centimeters limited to the breast is called as the T1 disease. 2 to 5 centimeters is T2 disease. More than 5 centimeters is what we call it as T3 disease, right? Now, when you notice, no, there are these structures which are going to radiate from the pectoralis fascia to the overlying skin, and this is what we call it as the Cooper's ligament. So this is the orientation of the Cooper's ligament that you have. Now the first one that you have is your less than 2 centimeters, 2 to 5 centimeters, and more than 5 centimeters, right? So this is what we call it as a T1 disease. This is your T1 disease, this is your T2 disease, this is your T3 disease. T3 is going to be size more than 5 centimeters. This is going to be between 2 to 5 centimeters, and this is less than 2 centimeters, right? So this is a T1, T2, T3. Now, what is T4A? Now T4A says that any size that involves the chest wall. Now any size that involves the chest wall, this will become our T4A. This will become our T4A. Any size that involves the chest wall. Now what is chest wall made up of? The chest wall is made up of your ribs, intercostal muscles, and the serratus anterior group of muscle. Pectorals major, minor do not form the component of chest wall. Now what is T4B? T4B is any size involving the skin. Any size that involves the skin will become T4B. It will become T4B. Now if it involves both, that is the chest wall as well as the skin, involvement of chest wall and skin together is what we call it as the T4C. This is what we call as T4C, right? Now if there is an inflammatory breast cancer involving more than 1/3 of the breast skin, if there's an inflammatory breast cancer, let's say this is the inflammatory breast cancer which is involving more than 1/3 of the breast skin, this will be called as T4D. This will be called as the T4D. So T4D is inflammatory breast cancer. This is your inflammatory. This is your inflammatory breast cancer. This happens to be your inflammatory breast cancer, right? So this is with respect to your T staging. Now here, how do you know it's a T4B? That is involvement of the skin. Involvement of the skin is given by either there has to be ulceration or there has to be Piode orange. Ulceration of the Piode orange will become T4B. So I now know it is having a T4B disease. Okay? Now, I have the patient who says ulcerative lesion, breast associated erythema is there, retraction, invested rectal carcinoma, no lymph nodes are given. So, and obviously there is no evidence of any distant metastasis. So M1 is ruled out. Now, is it stage 4 or is it stage 3B? Is if N1 and N3 is added to it? That's what they're asking, whether it's T4B. Now, when you look at this, your T4B sits perfectly here. The T4B sits perfectly here. T4B दिया हुआ है ना बेटा, ulcerated lesion associated with erythema of the surrounding skin and retraction of the nipple. ठीक है? Now, if that erythema is more than 1/3, is not describing it as more than 1/3. No. So answer here is going to be yes. Most of you are correct. It is going to be D for Delhi. That is going to be T4B. It's a T4B. That is going to be your involvement of the skin. End of discussion. Sorted. Clear है. ज़्यादा दिमाग नहीं लगाना. ठीक है? So that's your day 13. Let's go to the last one. That is day 14. Now, when you talk about the question on day 14, what does day 14 says? Day 14 says we have a patient presented with rectal prolapse. Which of the following procedure is not done via perineal approach? So when you talk about the approach in rectal prolapse, so first thing first, when you have a patient of the rectal prolapse, now this rectal prolapse is also called as procedentia. Okay. Now when you talk about the rectal prolapse, I have two forms of rectal prolapse. One is your full thickness, another one is partial. So when we have the partial rectal prolapse and the full thickness rectal prolapse. Okay. So partial rectal prolapse is those prolapses where the length of the prolapsing segment is less than 4 centimeters, and a complete rectal prolapse is where the length is more than 4 centimeters. That's the first criteria that you need to know. Now, it's a visual protrusion to the anal canal that you will see. Now, the most important in the rectal prolapse is management. Now, when you talk about the surgeries for rectal prolapse, surgery for rectal prolapse, I can divide them in two approaches. One is your perineal approach, another one is your abdominal approach, right? So one, we have the perineal approach, another one is your abdominal approach, right? Now, what are the examples that you can see in the perineal approaches, right? So what are the surgeries that are done in perineal approach? Number one is a very temporary procedure which is called as the Thyroid wiring. Now, Thyroid wiring is basically an anal encirclage. Then you have the other two procedures which are called as the Delrom's procedure. This is a Delrom's surgery and the Altamere surgery. And the Altamere's surgery. So Thyroid wiring, Delrom's and Altamere's are the perineal route of approach. Now we talk about the abdominal route of approach. In the abdominal route of approach, we have the Repstein. We have the Repsteins. We have the modified Repsteins. The only difference is in Repstein, no, the mesh is placed anterior. So there is an anterior mesh. In modified Repsteins, it will have a posterior mesh placement. This will have a posterior mesh placement. Okay. Now, Repstein, then you have modified Repstein. Then you have the wheel surgery or the wheel rectopexy. The wheel rectopexy. And next one you have the Goldberg-Freichmann surgery. It's the Goldberg-Freichmann surgery. Now in the Goldberg-Freichmann surgery, you will going to excise. We are going to excise redundant sigmoid colon. There is excision of sigmoid colon. So in excision sigmoid colon. Dhruv sir, in Telegram the stage is 3B. But okay, so you're saying that one we have posted in the Telegram, the answer says as 3B. That is what you're trying to tell me? A quick feedback, guys, if anybody is there. In the Telegram, the answer is given as 3B or stage 3B. Quick feedback. Okay, but okay, so here the answer should be your T4B is given. Now when you look at the stage 3B, no, what is stage 3B? So when you talk about stage 3B, now when you talk about stage 3B, it is going to be T4 with N0, M0, or T4 with N1, M0, right? So in that context, you have to, or T4 with N2, M0, all they will be called as 3B. What is 3C? It is NET with N is 3 and M is 0. What is 3A? 3A, you will have basically a combination of T2 or T3. T2 or T3 with either N0, N1 or N2. Okay. Now how do you remember it? Remember, if you have N2 as the highest one, this is 3A, T4 will be 3B, N3 will be a 3C. That's how you remember it. Now here if you're saying 3B, it should have either T4, N0, M0, right? He has not mentioned about the lymph node status. He has not mentioned about the lymph node status. If he says no palpable lymph nodes, if there's no palpable lymph nodes, only T4 is there, the T4, N0, M0 will become 3B. That is not wrong, right? But then again, it should have been given, the question should mention, see here, ulcerated lesion, breast associated erythema, surrounding skin, retraction on nipple on examination, biopsy revealed invasive. See, there is no mention whether the nodes are positive or negative. They should have said node negative, no clinically palpable node. Then I would have gone with stage 3B. But because there is no mention, the better answer will be T4B. I'll change the answer in the Telegram group also, but this should have been a better answer. Okay? So this is all that you should know in the compounding series for today. I would love to discuss a little bit more, but as you all know, we have BLS starting in another 3 minutes, right? So thank you so much for joining today. We'll resume back next week from the next 7 questions. That is going to be question number 15 to question number 21. Until then, thank you so much. Good night. See you. And if you have any questions, ask on Telegram. Bye-bye.